hello, and thank you for coming to my talk. I've been coming to the HIV Clinician Society talks off and on, I guess, the last 4 or 5 years since I started spending my time here, and I think it was long overdue that Francois roped me into one, so here I am, and then, of course, he can't be here. So just to give you a little bit more background, I spent almost half the year here, off and on, like the last 5 years or so, and I've been doing work in immune reconstitution and Iris with Francois, RHRU, and VITS during that time. So we'll get started, and tonight we'll talk about Iris. And I think one of the points I'd like to make, starting with the title, is that Iris is dramatic. It's catches a lot of attention, particularly the scenarios that aren't as favorable to patients. But it's not all bad. So what is Iris? And throughout this talk, I'm going to try to keep it clinical. There's a lot of immunopathology, but quite frankly, it's what I work in, what I'm interested in. But I don't think that near anybody really has a clue about what the exact immunology is with Iris. So I'm going to keep it clinical and keep it broad. So what is Iris? It's generally defined, and I stress the word generally, as a paradoxical reaction or response to an infectious process. And of course, I'm going to modify that in a minute. After the initiation of antimicrobial therapy and antiretroviral therapy, and it's immune mediated. And you'll also hear it termed immune restitution or restoration disease. I like Iris better just because it's sexier and it sounds better and it's easier to say. But importantly, it does have the other I in there, which denotes inflammatory, and that really is a hallmark of the syndrome. So the question is it really a new phenomenon? The answer is really no. We've known about paradoxical reactions outside of the context of HIV for quite some time, and descriptions go back to the 1950s, where clinicians would describe expanding central nervous system tuberculomas in response just to TB therapy in the 50s and 60s. And there was a pretty good review of this in '87. You'll see a lot of those references down there from the 80s and early 90s. We also see it in malnourished children, and this is where I actually got interested in this phenomenon and took care of malnourished children as part of a MSF program, and it was really remarkable to see these kids come in completely malnourished, like you've never seen before. You start refeeding them, and they would develop localized bacterial infections, joint pustular joints, and it was really quite amazing to see. And it was one of the first situations I had been in where you actually wanted to withhold a therapy that you knew was good, And so I think that's what we find ourselves in now, in the timing of TB and ART and cryptococcal disease and ART. And we also see it in neutropenic patients, bone marrow transplant recipients in particular, these fevers of unknown origin. Of course, we're always concerned about invasive fungal infections in the ICU and really go after diagnosing them, but part of that, what we're seeing is actually just the body reconstituting, and you get a generalized fever, and it's not necessarily bad. And transplant recipients as well, and pregnant women. There's a paper which reviews the occurrences of paradoxical or unusual infections in pregnant women. So it's not new, but what's happened is that back in 1992, Martin French first noted that 42% of HIV infections patients starting just AZT. Okay, so we talk about this being in the HART era, but it really actually started before, and just with monotherapy AZT, they were able to observe the increase in delayed type hypersensitive reactions to mycobacterial antigens. And in 5 of these patients, these subsets of these patients, they developed an illness that was characterized by fever and lymphadenopathy and pustular infection 1 to 2 weeks after starting. So this goes back to '92, and it was an astute observation which nowadays has spilled into quite a descriptive process, and there's no way we can go through all this tonight, but this was from a recent chapter that we authored, and it was not fun putting this together, but you can see Iris basically involves every organ system, and they're not only infectious etiologies, but also non-infectious etiologies. The autoimmune disease, Graves' disease. One of my favorites is from the dermatologic manifestations is granulomatous reactions to tattoo ink. So all of this is just really a multi-system phenomenon both infectious and non-infectious. And in the definition I gave you earlier, we classically think about it as an infectious phenomenon, which it usually is. I mean, the vast majority of cases, and certainly in the scenario we are here, it's infectious. And the list goes on. You know, you've got gastrointestinal, hematologic, very you know, bizarre, oftentimes bizarre, but the bottom line is you don't have to worry about most of this. It makes good headlines, but clearly most of these are rare case reports. So what are the types of iris? Well, there's two types, and you may hear the term unmasking. And unmasking is a new localized infection characterized by focal inflammation. So a lot of that stuff I talked earlier about, suppurative lymphadenopathy, pulmonary infiltrates, plus or minus cavitation. And there must be adequate opportunistic screening prior to ART. So these are patients that, you know, you are getting ready to start ART, they're overall asymptomatic, you do your TB back tests, your sputums, they're negative, you start ART, and then they develop these localized reactions. And then upon symptoms, you must, you know, unmasking must demonstrate a positive culture or a characteristic pathological process, which in the case of TB is usually a granulomatous inflammation. And it's often difficult to distinguish from incident disease. Okay, so this occurs after ART and you get TB. Well, what distinguishes it from just TB? Well, the timing helps a lot. And in the vast majority of iris cases, they occur within 3 months of starting ART. And that's really the window that you need to be paying close attention to. And quite frankly, the other things that can, you know, clue you in is that they often just look more sick. They often have a much more inflammatory response than just your TB, getting a cough and having a pulmonary infiltrate. So this would be just an unmasking. So you have, I don't know how well this shows up, but you've got a pre-ART chest X-ray that's normal, and then starting ART you get, you know, bilateral pulmonary infiltrates, and this was a patient that we had, and they go from being smear negative, back tech negative, starting ART 2-3 weeks later, you get this syndromic effect, and this particular patient was smear positive after starting ART. And then there's the paradoxical, and this is the sort of the more the manifestation that's more classically described in the history. And in general, it's a paradoxical clinical worsening due to a previously treated or partially treated pathogen in the setting of an adequate response to ART. These are basically the patients who you diagnose with TB or crypto or another infectious process prior to antiretroviral therapy. You start treating them for it, you start the antiretroviral therapy, and then they get worse, okay? Following ART, as I said, there's a new inflammatory process, and it can be at the original site of disease or at a new site of infection. And then this is also accompanied by the systemic symptoms such as fever and weight loss and white count. And this would be a case of paradoxical iris. And unfortunately, this chest radiograph doesn't show up quite as well, but up here in the right upper lobe out there on the periphery, you can see a little bit of a hazy infiltrate. And then, so this patient was being treated for TB, started ART, and then in that same region, then developed a localized infiltrate characterized by fever and the iris symptoms. So how much is there? Well, it depends on where you look, how hard you look, what you're looking at, and it depends on the definition and criteria used. That's been a moving target now for quite a few years until about 2008 when we all sat down up in Uganda and decided to draw up some case definitions, at least for the TB iris. So there are definitions for the paradoxical TB iris. Unfortunately, we don't have a lot of definitions or any definitions for any of the other forms of iris. There's some being worked out for cryptococcal meningitis iris, but those aren't official yet. And people have used things like, well, you have to have a rise in your CD4 count to, be, reconstituted. That's subsequently been dropped because it doesn't really indicate, true immune reconstitution. Some people have used HIV viral loads. In our study, we did mainly for the sake of showing compliance. You have to rule out other things, which we'll get to. And it also depends on how well you're screening your population. I mean, part of the problem with unmasking is you have an adequate screening. Well, you don't get smears on everybody, and you don't get back techs on everybody. So, and different recommendations say, different things, so you have differences in how you screen people, which then will affect, your proportion that will develop iris. It also depends on your underlying opportunistic infection burden. There's distinct differences between what was described in the mid-90s, where I come from, where everything was MAC or, MAI iris, versus here, where the predominant bug is tuberculosis, and we don't see those same types of bugs causing the iris manifestations that we do in other countries. And so it really depends on, what's underlying in the population, what your cryptococcal burden is, et cetera. And then I think some of it's left up to the patient populations. There's a lot of interest in host immunologic factors that would predispose someone to iris. IL-6 receptors, your cytokine polymorphisms, all these things that people think may be at least playing a partial role, because not everybody who has TB gets iris. So what's the difference? So this was from a study that just came out 2 days ago in Lancet Infectious Diseases, and it really helped out my talk because it kind of gave me a figure to keep going to and showing you. So like I said, it depends on what you're looking at. So in this first little slide here is any iris. So you take all comers. You take dermatological iris, cryptococcal iris, and that's what we did in our study. And you'll notice that it bounces around a little bit, but it's pegged, and this was a meta-analysis, and it's estimated that about 17%, if you look at all these different studies. Most of them are retrospective, and there are a few prospectives in here. Ours in 2008, Hadal and Durbin, and as well as a couple since. So you can sort of see those later studies sort of panning out there in the 20s or so. And then it kind of goes on, and I actually, some of this is cut and pasted in later, but I wanted to put this in here in full, not to overwhelm you, but just to sort of demonstrate how, when I first started was back in 2003, 2004, everybody was saying, gosh, 35% of people are developing iris, and you go talk to a clinician, they're not, well, I don't think 1 in 3 of my patients is developing it. So we had, and we didn't have any case definitions, and people were using different definitions. So you can sort of see the trend. The top group there is the tuberculosis-specific studies, only TB iris. And you can sort of see that trend, as we've gotten better at recognizing it and defining it, and definitions have come out. You sort of see it now settling out around in the teens. And it follows with sort of cryptococcal meningitis to a lesser extent. But that was just one of the trends I wanted to point out, and the difficulty we've had from an epidemiological standpoint, because there's no single marker, because there's no single way to diagnose it, and it is a syndrome. That's part of the difficulty we've had. So what kind of iris do you need to worry about? Well, we're going to spend a lot of time on TB iris, a lot of time on cryptococcal meningitis iris, TB because it's the most common, and there are some public health implications, as I demonstrated earlier with the patient who turned from smear negative to smear positive. Well, that's a big deal. And cryptococcal meningitis, it's common here. There's particular lack of access to amphotericin B and flucytosine, which are drugs that we know really impact on the outcome and the treatment of it. And it has it's the one iris that has a high morbidity and mortality. And then I'll touch on dermatological iris. It's benign, but I think it's very common. It's the most common thing I think that's recognized. And I highlight it because the issue comes up with the confusion of side effects of your HIV medicines or your TB medicines, and it's important to sort of understand that what you may be seeing is just a normal immune response, and you may not need to worry about it or change the drugs. And then we'll touch on a couple other notable manifestations, particularly if we have time. All right, so TB iris, it's the most common iris pathogen, and you can see this from the same slide that I brought. So it's between 7 and 43%. You can sort of see that it's now often, or about 17, they say 17.7% in the paper, so around 18% of patients will develop it. It can occur as early as 5 days after ART, but the median duration from ART to symptoms is about 8 weeks. And if you look at these huge case series, the vast majority, and I would say 80+% of the cases do occur within 3 months, which really helps you distinguish it from incident disease. And again, this is a just X-ray demonstrating the phenomenon. So issues in diagnosis, you have to distinguish it from failure of TB therapy. A new opportunistic infection, is it really TB, or is it pulmonary crypto, or a simple bacterial infection? You have to rule out non-compliance or a non-response to ART. But usually these things are not that common. And what you're seeing, usually is iris. And recognition of it is essential because you need to not assume that it's a failure of the TB drugs and go switching their drugs. And similarly, you don't want to be changing ART regimens when you don't have to. And patients who are initially treated for pulmonary TB will commonly develop extrapulmonary TB iris symptoms. So it's something important to look for. This is a classic lymphadenitis, suppurative lymphadenopathy picture from a patient with TB iris. The symptoms there I've mentioned mostly through the talk here already. In particular, there's some others like new pleural effusions. Hepatomegaly, you need to be looking systemically, so you need to also be looking at the liver and spleen and meningitis in particular as well. This figure is from Steve Lawn's paper a couple of years ago in the Blue Journal, as we call it. And it's a nice little figure in that it shows what the relationship is here. And the key thing here is that most presentations of TB are in that middle. They're normal, okay? On the lower left-hand corner, you've got TB that's subclinical, and then on the upper right, you've got overly inflammatory presentations of TB, which is the iris or IRD. And what we've learned here is that this is dependent on a mycobacterial antigen load, as with other infectious antigens, and also related to how quickly you immune reconstitute. And really the measure of that is not ideal, and things like a simple CD4 count don't necessarily translate into how you're recovering immunologically. So risk factors are pretty straightforward. You have a shorter interval between ART and TB treatment initiation. Lower baseline CD4 count seems to keep being a prominent feature. Extrapulmonary TB is, and a rapid falling viral load is what some people have found, although lately that hasn't panned out as much. And then significant increases in your CD4, like the rate of the CD4 rise or the percentage, is often always cited as well, although I think recently that's been less of a factor. But the two that really sort of hint back at that previous slide on your mycobacterial antigen load or a shorter interval between your ART and your TB treatment. So the shorter interval you have, theoretically, the more TB bug you still have in you. And then the extrapulmonary TB, which is really a symptom of really just a larger mycobacterial burden. So how do we prevent it and treat it? Well, there's a decision analysis 2-3 years ago which showed that, there's a modeling that showed that if you increase the duration between ART and TB, you can decrease the incidence of iris. And then we do know that, in contrast to the benefits of early ART or ARV therapy in patients with active TB and very low CD4 counts, outweighs the risk of the TB iris. So on that last point was the paper by folks in Durban that just came out, referred to as here and there as the SAPIT trial, but it was, now it's the timing of ART and TB therapy, and they basically took 642 patients. They have an early integrated group where they started ART within 4 weeks of starting TB treatment. The second late integrated group was ART within 4 weeks of completion of the intensive phase, so i.e. after the 2 months, you then start ART. And then a sequential group, which started ART within 4 weeks of completion of TB therapy. So quite a prolonged start of antiretroviral therapy. And what this has taught us from the iris perspective is that, it's taught or verified what we're coming to know. The later you start ART in the setting of TB, the higher the mortality. And the separation here between the two groups, they took the integrated groups and put them together in the end, is quite different. But from the iris standpoint, it was interesting that the integrated groups started ART about 70 days after TB therapy. So they started about at the completion of the intensive phase. And 12% developed TB iris. And then in the sequential group where you go through and you treat their TB in full, which I don't think we'll be doing too much of from this point on, very few patients, 3-4% develop iris. So what this tells you is that the more you treat, the more you lower that antigen load and the less likely you are to have iris. Well, there was a steroid randomized controlled trial done down in Cape Town that looked at prednisone for the mild to moderate TB iris. And these are the criteria that they used. They then dosed prednisone 1.5 mg per kg for 2 weeks and then tapered down. And measured, the outcome was basically cumulative hospital days, and then they also measured symptoms, and they had a thing to calculate. And in the end, there was no difference in the mortality between steroids or no steroids. But what they found was that the cumulative hospital days and procedures in particular seemed to be less in the patients who received steroids. And they had significant improvements in other things like symptom scores, pulmonary infiltrates, and Karnofsky performance scores. And they also looked at things like CRP but didn't see a difference. And what they did conclude, though, is that rifampicin resistance is important to exclude, because out of all of these, they had about 110 patients in the study. They found about 10% were resistant when they had all the bugs and they did in-depth cultures and sequencing. So in short, the summary for TB iris is go ahead and initiate ART early despite the risk of TB iris. It's mostly mild to moderate. Don't be too afraid of it. There are the case reports of tracheal compression and lymphadenopathy and ARDS and these things that do get your attention, but they really are in a minority of patients. And if you really delay ART, you're really adding to mortality. But do pay increased attention to the patients who have extrapulmonary TB who you are starting on ART. And pay any attention to someone who presents with any respiratory symptoms after starting ART, because they're the ones who may have fluffed out that infiltrate and now may be smear positive when they were smear negative before, and it has important public health implications. Mortality is very low, less than 1%. And then from the Graham study in Cape Town, considering adding steroids when you do have mild to moderate iris to help mostly with symptoms. Okay, so now on to cryptomeningitis. And cryptomeningitis is a big problem both where I come from and here. Even in the best case scenarios, some of the mortality suggests that even in the US and high income countries, the mortality is 10 to 25%, but it's even higher here. And it's due to a number of factors. This is from a Malawian randomized controlled trial of fluconazole monotherapy versus fluconazole and flucytosine. And you can see even with, and they used high doses of fluconazole here. They used 1,200 milligrams of fluconazole, and you're still looking at, 45% mortality, and even worse if you use monotherapy. Okay, so you're looking at, between 50 and 60% mortality. So we need to discuss this. It's still a big problem. This is from Cape Town. On the shaded area, you see the rollout of all the ARVs, and then they have the number of positive India inks across the years by month, and you see it's still there. ART is not really making an impact on how much they're seeing microbiologically. So how much is there? Well, again, from that little slide, it's a bit, you see the confidence range there is a bit wider, but somewhere between 19 and 50% of patients who have a history of cryptococcal meningitis, who are those patients, will develop it. So I think it is higher than TB. Clinical features, it is very abrupt and dramatic. And when you have these patients, they make an impression on you, okay? Take-home point is that most forms of iris are really pretty mild and will pass, and you don't need to change ART, and you don't need to do a lot of stuff. But cryptococcal meningitis is different. You can get relapsing and paradoxical cases, even in patients you knew who have cryptococcal meningitis and you've treated with even amphotericin B. There's cases where they will then get a paradoxical response, and these are often cultural negative. Okay. And higher CSF opening pressures are also observed in these iris cases, and CSF pressure is directly correlated with mortality. So that really tells you what you're up against. Risk factors, again, it's ART initiation within 30 to 60 days, so you get closer initiation. Some of these were found in some studies like unknown HIV infection, but fungemia in particular, and high serum CRAG titers. And you could probably throw in the positive culture at 2 weeks. And I think the low baseline CD4 count keeps being a predictive factor, because it's really a measure of probably how much antigen burden you have. I mean, lower your CD4 count goes, the less you're able to fight off infection, and concurrently the more antigen load you have. So morbidity and mortality is substantial. You can have seizures, hemiparesis, dysarthria, permanent neurological sequelae from your meningitis, and mortality. The estimates are wide, but it's anywhere from 9 to 66%, depending on which study you look at. And in that recent Malawian paper I showed you, when they looked at cryptococcal meningitis poor outcomes, what was the issue was that there was unrecognized elevated intracranial pressure and a lack of repeated lumbar punctures. So why is it so deadly? Well, the crypto bug is an encapsulated organism, okay, like your streptococcus, like your meningococcus, and it's got a polysaccharide capsule with lots of nice sugars that are very antigenic. And what was first done, and they actually took a mouse model a couple years ago and then, artificially injected them, but the key point here is that the cryptococcus bug is able to get into the meninges and into the brain parenchyma, and they actually start degrading the capillaries within a matter of hours. So it really has a propensity, and it sets up shop in the arachnoid space. And the top portion here is from Cape Town, where they actually did some post-mortems and found the cryptococcal bug distributed through there, and it forms a lot of granulomatous inflammation. And that's how it actually raises intracranial pressure, because you don't get the drainage, and it has a high impact. But it's just very antigenic. There's something different about it. So what we do know, and recently some suggestions have come out, like TB. There was a large ACTG trial that showed the earlier start of ART in general leads to improved outcomes in opportunistic infections. I don't argue with that. They had 30 patients or so in this of hundreds who actually had cryptococcal meningitis. And then the problem is that there were a very small number of patients overall in the study, and then of course some of the other suggestions about this have been that there have been sort of historical case comparisons. And sort of throwing fire on this is that there's an abstract that suggests that the earlier you start ART in the setting of cryptococcal meningitis, actually maybe the higher mortality that you have, and this was a randomized controlled trial. I haven't seen the publication since, but certainly provocative, and I didn't see sort of specific mention of iris, but you wonder, unlike the TB and the other forms of iris, does this have a significant mortality that is resulting in what they're seeing here? I put this in here because you need to understand, what you're up against in terms of treating cryptococcal meningitis. And these are some wonderful studies that have been done by Mechanic down in Cape Town and Harrison and some folks who do a lot of cryptococcal work. And they actually are able to measure what's called the reduction in the log colony forming units in patients. And they've done this across a number of different doses of antifungals. And you can see if you're using fluconazole 400 milligrams a day, you're not actually doing anything. It's fungus static at best. So when you start going up to 800 and 1200 milligrams a day, you can start seeing maybe at 1200 you get a reduction of 0.18. Okay? To put this into context, amphotericin B and flucytazine will give you about a reduction of 0.55. So it's still only about less than half equivalent, even at these high doses. And there'll be more data coming out from the Malawian trial I showed you, where they actually were able to obtain a little bit higher with the flucytazine, but still shy of ideal. So for the take home from that is that the time to sterilization of your CSF is actually pretty long, okay? So sterilization can range from 21 to 64 days, which is important when you're considering, starting antiretroviral therapy. There's no randomized controlled trials for cryptococcal iris management. And there's anecdotal evidence that suggests that steroids may reduce meningeal inflammation and neurological symptoms. But I really caution against the use of steroids. You really need to make sure that your CSF culture is negative before you start giving high-dose steroids, because in the cases where it wasn't negative, you get just a worse outcome. Now, other issues that come up in terms of management, how do we actually treat patients that we draw serum cryptococcal antigen titers on? The interesting thing that came out from, again, Cape Town was that they took stored specimens and went back and measured these on 707 patients. 46% had a positive CRAG. They knew 21 of these patients had a history of cryptococcal disease, but there were 25 who didn't. And they went back and looked at what happened to these patients. And kind of frighteningly, 7 of 25 developed meningitis at a median of 35 days after the initiation of ART. So, there's no, recommendations about what to do with serum CRAGs yet, but I sort of, wonder if you at all suspected and you draw it and it's positive, I would treat. So, consider administering high-dose antifungal therapy for starting 4 weeks before starting ART. That's not, it's sort of preference from folks I've talked to in Malawi and what they do. And you really do have to use high dose, and repeated lumbar punctures are important. You want to really document clearing of the CSF before you even entertain steroids, as I've said before. And we have had a couple cases where people have had cryptococcal meningitis. It's been pretty well treated. You tap them, it looks negative, but they still have just a profuse inflammatory reaction. And in those cases, we have once or twice actually stopped ART. When you know that the culture is negative and what's really driving this is really just a lot of immunological inflammation, it can be considered. But usually you don't have to, and particularly if it's culture positive, you actually really do need your immune response. So the next area is the dermatological irises, and I'm no dermatologist, but I'll tell you that it's probably the most common form of iris, and not probably, it is. I mean, there's a lot of case series, even from the UK, our study here, Easterbrook and Company down in Durban. Of course, they had a dermatologist on their study, so surprisingly, they had like 60% cases of dermatological iris. But really, actually, in their study, they had 27% of their iris cases were actually pruritic and folliculitis reactions. So they, had a very high rate of dermatological manifestations. And it's, it can present as a number of different ways. There's never really going to be a standardized case definition for dermatological iris, and it has to just do with recognition and knowing that what you're seeing is not necessarily a reaction to the drugs. They vary widely. This case here on the left was a case we had. This gentleman had a tinea capitis before starting ART. He had, was treated with sort of topical antifungals on his head. Got started on antiretroviral therapy, and then just developed, you can see just a diffuse pustular reaction throughout his the back of his head. Fortunately, it responded to antibiotics and continuation of ART. And one of the most common things there on the right is what we call the folliculitis or immune recovery folliculitis. And I call it the good iris because, really if you see a patient that comes in with, a folliculitis, you know that they're reconstituting appropriately. And I had my first child 8 months ago, and it was really neat seeing him a couple of weeks after being born. That's what they do. They actually develop a folliculitis as they're, they get colonized with the bacteria and they have to mount a response to it. So it's really part of the normal reaction. Where it's abnormal is when you get, and where you need to pay attention, is when you get the big subcutaneous abscesses and things that really are limiting and significant infections. So be not afraid. You treat the episodes as you normally would. I think what's really important though is patient education. Letting them know that this isn't necessarily the HIV drugs. Okay, that it's partly as a response to them, but it's not something that they need to stop taking their drugs and affect adherence. It's these are often the dermatological ones are actually often the most complained about because they're itching or they get an abscess. But I think you need to really set the stage and really sort of get patients through it, and they're temporary. And change the medications only in cases when you know that they're probable drug reactions. And how to best discern that? Well, if you're developing folliculitis and things like tinea capitis and pustular abscesses, then that's most likely not. So you want to just keep an eye out for the drug reactions. I want to touch on this just because I think it's often underreported. So there's an iris called immune recovery uveitis and vitriitis, where you actually patients who have a history of CMV infection in the eye, either it's subclinical or previous, will, upon starting ART, develop visual disturbances, floaters, and such that are iris manifestations. They're important because they require specialized therapies, and there's limited access in a lot of places to ophthalmologists. And these types of reactions and these types of irises actually require, local steroid injections, ocular injections, a lot of specialized therapy. And to date, all these studies on there are from developed or high-income countries, and you can see it's actually pretty high, and that's pretty consistent across cohorts. But there is some data in Botswana that's being discussed around. I haven't seen it formally presented yet, but I bring it up because I think ocular complaints are not something that we often really inquire about, or that necessarily the patient will tell us about. It's usually the headache or something else. But they examined, I think, over 300 patients, and they did sort of serial slit lamp examinations, fundoscopic exams, and noted ocular inflammation in about 10% of their patients that are starting ART. And it all occurred within the 16 weeks, the classical iris time. So I think, bring this up, there's not a lot of data where we are right now, but I do bring it up to keep in the back of your mind. It's often the iris that we don't really talk about a lot. So I want to touch on pediatric iris, because I know if I don't touch on pediatric iris, the pediatricians will be upset. And I work partly in the pediatric iris as well. And they do have a number of differences with adults. So the take-home point between TB iris is that it often presents as it is in adults. Same sort of duration, range of dates, presentations of parenchymal infiltrates. There's really not a lot of difference in the presentation of TB. One of the differences, though, when you look across the big case series, though, is that the viruses are common. Okay, varicella zoster in particular, and herpes simplex are very common manifestations of iris in the pediatric population, accounting for probably roughly 25 to 30% of the cases in series, and most of that comes out of Southeast Asia and Thailand. And they're manifested by mild to moderate ulcerative eruptions. And fortunately, there's only, when I did a thorough review, there's not really an increased risk of dissemination from this. And there's only one case of encephalitis-related iris case. So that's fortunate. And the other fortunate thing in the pediatric population is that cryptococcal meningitis iris is uncommon. Now, overall risk factors, study done here at Helen Joseph found that a younger age, 7 months versus 10 months, was a risk factor. Again, like in adults, people suggest a lower baseline CD4 count or percentage and higher baseline HIV viral loads, which are risk factors that we are reported again in adults. But one interesting difference is that there was a study in Peru that was done, I believe, by Wang et al., and they found lower baseline CD4% and a higher viral load, but also one marker of malnutrition. And I presented in one of those slides earlier that it's common in refeeding children, and in the case where they published that, I think it was in Kenya, it was in the 20% of kids developed a refeeding syndrome or iris. So we know that this can happen independent of HIV, but it looks like even in the context of HIV, it may be an additional risk factor, or they're acting synergistically. And we know that malnourished kids respond very different to antigen stimuli. They don't have the memory T cell population that well-nourished kids have. So we do know that they're immunologically different. And one of the studies we're doing down in Heretschizi, Hebera, is looking at TB, BCG, and malnutrition in the context of iris here in Johannesburg. So we'll see what happens. We've started a few months ago. And then the other distinct difference between adults and kids is that kids have the manifestation known as BCG iris. And in one well-described cohort here, about 13% of kids developed BCG iris. Again, it occurs within the 2-3 months of ART with a range up to 2. And it's characterized by ipsilateral regional disease or ulceration, and oftentimes abscess formation at the injection site. So kids will come in and actually have an abscess right where they got their injection. And this is a child here that has the sort of classical ipsilateral nodal disease. It's important to know that disseminated disease with bone and pulmonary involvement is possible. It is uncommon, fortunately. Most of BCG iris is treated symptomatically. If at all, you need to lance any suppurative eruption, but most of them resolve pretty well. And the use of non-steroidals and corticosteroids in the pediatric population is very uncommon, and most of them do resolve. So where do we go from here? Well, I think the management and the immunopathology of cryptococcal meningitis is still a big area to work on. The mortality, just associated with cryptococcal meningitis in general is high. And then you add on the complexity of starting antiretroviral therapy in the context of someone who has cryptococcal meningitis. The access really to only fluconazole, high dose at best, it really puts us in a difficult situation. I think this is where the next, randomized controlled trial or very well done study needs to come to sort of discern out what we do with this, because it's a big issue. And there's some working, as I mentioned, some working case definitions that are being developed for both the paradoxical and unmasking forms of Cryptococcal iris. I mean, do we use serum cryptococcal antigens? If they're positive, do we treat them all? Do we treat a certain titer? What impact does that have on iris? I mean, all these are really important things. And then the other area that I'm particularly interested in as a pulmonologist is the role of pulmonary TB iris in the incidence of what's been termed post-ART, or I don't like the term, but it's being thrown around, ART-associated TB. It makes it sound like TB is due to ART. But the phenomenon whereby, as I showed you earlier, where someone who's smear negative can develop a localized pulmonary infiltrate and then convert to smear positive is a very interesting scenario, and it has big public health impact. How many of these patients do that? I don't think anybody can really say. Breen and colleagues have, wrote a piece a couple of years ago, 3-4 years ago, about this, and really, postulated, does it actually contribute to, some measurable increase in incidence of TB after you start ART? I mean, overall, the beneficial effects are there on of ART on TB incidence, but what happens in that first two months? And I think some additional work can be done there, and especially in terms of screening. Like, how do we screen these patients to identify those people before they do that? And then I think just the overall impact on ART programs needs continued assessment. I mean, we sort of talk about the number of patients now in antiretroviral therapy, and it's quite exciting and commendable. But if truly 17% of patients are developing some form of iris, and out of that, serious forms, i.e., bad TB, cryptococcal meningitis, it's probably in the realm of a few percent. But still, when you start looking at the absolute numbers, and you don't have to go very far to go up to the ward and see that you're admitting people to work up a lot of these conditions. It has a significant impact on the healthcare system, and I'd really be interested to know sort of monetarily what that impact is, as well as manpower, and I think it would be interesting to see that, because I don't think the mortality is there. It's really about associated morbidities and what the resource impact is. And so, just finishing what the quote said, it may be said with a degree of assurance that not everything is MECI as it appears, and I think that iris is just one of the facets of HIV that we've come to recognize that with. We've gone from HIV, AIDS, not having any therapy, to monotherapies, to heart, and now our attention is shifting towards the metabolic consequences, the long-term immunological impact, and the introduction of all this has really changed and brought out what was there in numerous populations, but really sort of expanded things and made it, the problem that it is today. So.